Good evening, all the respected dignitaries and academicians. We Indians are proud of our culture. Ancient Indian scriptures have told us about Panchatattva. World is made up of 5 elements: Prithvi, Aap, Tej, Vayu, and Akash. Ancient India has given this world many discoveries for betterment of human life. The importance of water was then known to us. We all know that an adult human body is having 60% of water, and for children it is more than 78%. And in continuation with the tradition, in recent past, in 1971, an Indian pediatrician from Kolkata, Dr. Dilip Mahalambis, pioneered the use of ORS in diarrheal diseases. It was then its importance was established during Bangladesh War. He left this mortal world on 18th of October 2022 at the ripe age of 87. A great human being, he is immortal through his work for serving the lives and saving thousands of lives. We are still using his ORS in different form, and we today, Maha-AP with Raigad branch, want to pay homage and respect by dedicating this episode of Journal Journey to Dr. Dilip Mahalambis. Now may I invite Dynamic Vice President of AHA, Dr. Swati Likhite, to take over for further proceedings.
Thank you so much, Madam, for your kind words. Good evening, each one of you attending today's Journal Journey. Myself, Dr. Swati Likhite, welcome you all for today's session. Today we have two very interesting topics for discussion with excellent speakers and eminent experts. So I'm sure we all are going to enjoy today's discussion. Now I request Maha-AP President Dr. Ramakant Patil Sir for his opening remarks and welcome address.
I am mesmerized and overwhelmed by the galaxies of IAPNs and who's who of IAPNs today. Dr. Nitin Shah, Dr. Umesh Vaidya, and this program from whom it is, and Dr. Bela Verma, who is my CIP colleague in 2022. Dr. Nitin Shah sir, one of the person IAPNs who has got fastest celebration, and I am really happy to be him as a guest of honor for this wonderful Journal Journey program. And this Journal Journey program is possible because of contribution of Raigad IAP and mainly by Dr. Nimen Mohanty sir and Chitra Kulkarni madam, and ably supported by Dr. Vikas More and Ajay Puri. And it has been really every month we have not missed, and this has been before Dr. Last year's president took over. Before that also it was from Raigad IAP, and it is every month this Journal Journey program is being carried out on first of every month, with the exception of only once. We could not take it on first of month. And we have got another experts, Dr. Umesh Vaidya, who is from my alma mater, who is 2 years senior to me in BJ Medical College, Pune, and who has pioneered neonatology practice in Western Maharashtra. And also Dr. Bela Verma madam, who is HOD in Grant Medical College and JJ Group of Hospital. And I have seen her very honest and forthright person, calling spade as a spade, but helping to all. And we have got a personal experience when we were about to miss a flight, but madam stood in the door and she made that flight to wait for us, and we could enter and go to Delhi. So with this, I will like to welcome our two speakers, young people. One is Dr. Sachi, who is neonatologist from BJ Wadia Hospital, and Dr. Prashant, who is also neonatologist from Chhatrapati Sambhaji Nagar. And we are all ears to listen to all these two presenters, and along with them the expert comments from Dr. Umesh Vaidya and Bela Verma madam, and the guest of honor telling us whenever Dr. Nitin Shah speaks, everybody just listens, and we will be again listening to him. Over to you, Likhite ma'am. Thank you for giving me an opportunity to say few words.
Thank you so much, sir, for your encouraging words. And moving further, now I invite Maha IAP Secretary Dr. Amol Pawar to welcome our today's guests.
Thank you. Thank you, ma'am. Here I am to introduce my mentor in IAP, Dr. Nitin Shah, sir. First of all, welcome all the dignitaries, delegates, and experts, and Raigad IAP team, Maha IAP team. Dr. Nitin Shah, sir, is mentor to many. He is a teacher of teachers. He has done MD Pediatrics from Bombay University in 1985, DCH in 1985 again. He is a section head at in pediatrics and consultant pediatrician at PD Hinduja Hospital, Mumbai. He is an honorary hematologist, oncologist at BJ Wadia Children Hospital, Mumbai. Then he is a visiting pediatric hematologist, oncologist at Apollo, Navi Mumbai also. He is a member of Lancet India Pediatric COVID Task Force in 2021. He was a president of IAP in 2006. Then he is also a fellow of IAP, which he got in 2018. He is a chair to Pediatric Hematology Oncology chapter of IAP in 2015-16. He has edited many textbooks of IAP. He was there as a chairperson, scientific advisor, co-chairperson in various committees of immunization. He is called as Vaccine Shah to and everyone in all over world. He is recognized as Vaccine Shah. So he has edited many books other than immunization also, and he has conducted many modules. He has trained various people, various PG students under him in various hospitals like Wadia and PD Hinduja Hospital too. So without so this is from my side, and all the best to experts, and welcome Nitin Shah sir once again. Thank you. Thank you. Over to you, Swati ma'am.
Grateful to you, Dr. Amol. Now I invite Dr. Ram Gopal Chhajera, Organizing Chairman of Mahapedicon 23 Thane, to introduce our chief guest, Dr. Nitin Shah.
Dr.
Actually,
Shah
yeah.
is introduced already.
Yeah, so we go ahead. Now I invite Raigad IAP President, Dr. Vikas More.
Dr. Ram Gopal, wait 1 minute, ma'am. Is Ram Gopal sir is there? So let's have 2 words from him. Then we'll move ahead.
No, sir. Ram Gopal sir is not there.
Not joined.
Not there. Okay. Continue. Please continue. Sorry.
Okay. So I invite our Raigad IAP President, Dr. Vikas More sir, to welcome our dignitaries.
If he has not joined, we can go ahead.
Fine. Now I request our guest of honor, Dr. Nitin Shah sir, for his blessings towards our journal journey and share his pearls of wisdom.
So thank you organizers for inviting me today. I am actually, you should have told me I am the host of honor, not guest of honor, because I am one amongst everyone who is present here. And it's really pleasure to connect with so many young people who have taken over the mantle of IAP. Especially I will take the name of Dr. Ramakant, who is a absolute visionary and the correct person to head Maha IAP, and has done some wonderful work. He has also withstood, and he said that Dr. Bela said a spade. I know Ramakant also calls a spade. So in that sense, he has been a real pillar of strength. Amol, of course, is the youngest Turk who is, I'm sure, in the coming decade will become a very important person from Maha IAP to head somewhere in the central IAP. And I'm really... I'm really happy that this legacy which was started 2-3 years back by Dr. Mohanty about starting the journal club in the form of journal journey Now that is 3 years is almost like a journey rather than only a club. So it's aptly titled as Journal Journey, where I'm sure everyone knows that you take 1 or 2 articles of very importance which have appeared recently. You discuss what the articles were and give insight. So for people who are lazy to read articles and what is latest, it's a ready-made decoction that they get. It's like an instant coffee for them. So it's said that the books are at least 20 years old. The teachers are even more than that. And the journals and the articles are actually the ones which are the recent ones. So everyone who has read their textbooks should read journals so that you can understand what is the latest, because it's generally seen that people remember what they've learned as resident and then they think that's the gospel that continues for decades, but that's not true. Like we all have written caltin with neomycin, volumycin, pactogab, then pactogab mf, gramone, gramogil, and I'm not ashamed of saying I'm one of them. But today if I see that, I mean from one of my students, I will fail that student. So only we could update is only because we read and we engage. So one of the very important reason why one should work for IIP is that when you work for IIP, get used to expert speaking in conferences, in such program, so that you automatically develop that habit of reading, and you also become more learned than what you were. So kudos to IIP Maharashtra branch for conducting and continuing this activity. Kudos to IIP Raigad for actually innovating this idea under Dr. Mohanty's guidance and continuing this legacy now. And I'm especially happy today is because one of my own student, our DNV student from Hinduja Hospital, Dr. Sachi Jain, now who is doing a fellowship in neurology at Wadia Hospital again, she is one of the person, and she is going to speak on a topic, or she's going to review a topic which is very near to my heart, because as I say that hematology oncology is my profession, but vaccination and immunization is my passion. So she has touched my passion today by selecting the article on side effects of preterm. And I know who better than Umesh and Bella to be experts, especially Umesh for the first case, because people are very scared. I mean, we discussed as recently last week as to when should you give a preterm baby vaccines. Should you give it while it's in nursery? Can oral polio vaccine spread to the other babies? Can rota be given safely in a nursery where other babies are there? Some of them be immune compromised. A baby who is little apneic, this, that, can you give him DPT containing vaccine? Will it lead to more apnea? So many questions. Hepatitis B, should you wait for 2 kilos or at the time of discharge? BCG, is safe to give in a newborn? So I think these are the things that are really bothering people. So generally people avoid giving vaccine till the baby is on the day of discharge, or sometimes even wait for a week's follow-up after that. But believe me, you can actually start all the vaccines chronologically, including hepatitis B now. Now it is believed that there's no need to wait till 2 kilos and things like that. So that's a new change that has happened in the field of immunization. So I think with that word, and of course, an excellent observation by Dr. Dilip Mahabanilis when he was working at the border of India and Bangladesh during the war. He found that there was a huge outbreak of cholera. He made his own solution because IVs were just not available, not possible, because there was no trained staff to give IV to everyone. And so he randomized to people receiving his own solution and people receiving any other fluid or IV. And to his great relief, the people who were taking his solution actually survive better. And that's how he knew that this ORS works. And the principle of sodium, glucose directed sodium reabsorption and things like that. But that was for cholera. And we know in cholera, the stool output fluid electrolytes are as much as in plasma. And whereas in acute watery diarrhea in children, the sodium loss is not as much. So probably we were giving too much of sodium when we were using the original ORS. So then the revisions were made by WHO expert committee. And that's how we have come to the current low molecular or low osmolar ORS, which is actually the one which you should use in acute watery diarrhea, except the ones which are cholera. So cholera, you must still use old one, but the new ones you should use for all other acute watery diarrhea. So I think these two very important topics. In fact, it was the invention of the century, as said that ORS, which actually helps save millions of lives world over, not only in developing countries, but all over, including the Western countries, adopted the only solution to be used in diarrhea is ORS. So I'm very happy that both these topics are of extreme relevance for today's practitioners and that they've been chosen by the scientific committee. I will not stand between you and the speakers. So I will hand over mic back to Dr. Likhite and Dr. Chitra Kulkarni to conduct it. And we will be very happy to hear from these two speakers and then the comments from the experts. Thank you.
Thank you so much, sir, for your kind words. And now I invite Dr. Chitra
Swati ma'am.
Netare.
Swati ma'am, please wait for 1 minute. Dr. Vasant Khalatkar sir has joined. So,
Okay.
Chitra ma'am, can we have 2 words from Vasant sir? Please.
Yeah, sure. He is expert in infectious disease, and today's topic is one of the topic is ORS. Yes, Dr. Vasant Khalatkar, please.
Yeah, thank you for inviting me as a guest. Really, after Nitin Shah sir, nothing to say. I know. Thank you, Dr. Bela Verma, Madam, Nitin Shah sir, and our Umesh, and both the presenters for sharing knowledge. It's really great thing, and thanks Raigad IP along with Maha IP for continuing this journey. Mohanty sir, really, I want to thank you. I will not take your time. I wish all the best for this program. That much and more journal club program should be there in future. Thank you.
Thank you,
आपण
Dr.
आज सायंटिफिक
Khalatkar.
प्रोग्राम साठी सगळे जमा झालो आहे, पण लेट मी से दिस मॅन इज वर्किंग सो हार्ड फॉर IIP. I mean, we have to support him. We have all to come together. And I earnestly appeal that we must this time see that Vasant Khalatkar becomes the chief of IIP.
Thank you. Thank you.
Thank you, sir.
Thank you, Nitin sir. Yes.
Moving forward, I request Dr. Chitra Netare, madam, to give her blessings towards our Janna journey.
Yeah, Chitra ma'am is.
Good evening, ma'am, and thank you very much for the opportunity. I'm really feeling very honored and privileged to be a part of this esteemed team that is present here, and your enthusiasm is really very contagious. So I look forward to this treasure hunting that is going to take place now in the next few hours. And as Dr. Nitin Shah has already mentioned, that this process of learning and unlearning, which plays a very important role. And in adult, as pediatricians, all of you are playing that role in private practice, as well as maybe in academics, if you're attached to medical colleges. But this is a very virtuous quality where unlearning part is a little difficult. But with this process of CMEs that take place, journal clubs that take place, this does happen, and it keeps us updated. So I look forward to becoming a part of this lifelong learners, all of you that are present here, and enjoy this session along with you. So thank you very much.
Thank you, madam. Thank you so much. Now I invite coordinator Dr. Jay Bhandarkar sir to introduce our first expert, Dr. Umesh Vaidya sir, and from Pune, and also our first speaker, Dr. Sachi Jain, and her topic is adverse events after vaccinating preterms.
Thank you, Swati. It's my pleasure to introduce Dr. Umesh Vaidya sir. He's the head of the neonatology of KM Hospital, Group Director of Ankara Hospital, Pune, and very senior neonatologist, and pioneer in many things in neonatology. I personally attended workshops of him in many conferences. So thank you again. And for others information, on the 1st July, 3 years back, Raigad IP started this, myself and Dr. Hemant Gangulia. This is a journey journal and Mohanty sir. And I was the first presenter. Thank you for that. And I have to introduce speaker first. So Dr. Sachi Jain, as I said, she's the MBBS from the Rajiv Gandhi Medical College, Karwa, Thane. DC has done DCH from the St. GS Medical College and BJ Wadia, Mumbai. DNB Pediatrics from the PD Hinduja Hospital. And she has done IIP fellowship in neonatology at BJ Wadia Hospital for the children. So welcome, Dr. Sachi. Thanks for accepting the invitation as a speaker to this journey journal. Thank you.
Dr. Sachi, you may share your screen.
Yes, ma'am. Is my screen visible?
Yeah,
Yes,
go ahead,
yes.
go ahead.
Yeah,
Yes,
yeah.
yes.
A very good evening to everyone. I would like to start the presentation. Moderator is Dr. Bhavya ma'am from Wadia NICU. Topic is the cardiorespiratory adverse events after first vaccination in preterm neonates of gestational age less than or equal to 30 weeks. It was published in Indian Pediatrics Journal, volume 60, June 15, 2023. Introduction. Vaccination is an effective way to reduce the morbidity and mortality for the vaccine preventable diseases. And preterm infants are more susceptible to these vaccine preventable diseases. The WHO and the ACVIP guidelines, they say that all the infants should receive immunization regardless of any restriction based on the gestational age and the birth weight. Still the exception for hepatitis B. Need of the study because there is a lack of literature about the vaccine policies and the actual practice from various centers that deal with the preterm care, and also to measure the clinically significant adverse effects that would be the first step to design the recommendations to decide the optimal timings of the vaccination. This study was conducted by Dr. Hema Sundaran ma'am at KIMS Hospital, Kerala. It was conducted in the Department of Neonatology at Kerala Institute of Medical Sciences, Kerala, and it was a retrospective study. The aim and objective of the study included, it had to document the adverse cardiorespiratory events which occurred following first routine immunization in a preterm neonate. The methodology included, they included the neonates of less than or equal to 30 weeks of gestation who had completed their care in the NICU between the period of June 2018 to June 2022. According to their unit protocol, they administered BCG and hepatitis B to those babies discharged before 8 weeks of postnatal age. The birth dose of OPV was not given, and hexavalent vaccine with BCG, rotavirus, pneumococcal, all were given at 8 weeks of postnatal age if the hospital stay was expected to be longer. After vaccination, these babies were monitored for a period of 48 hours with pulse oximetry. And if they were on any ongoing support or any cardiorespiratory event occurred, then the monitoring was shifted to multi-parameter monitoring using ECG leads and non-invasive BP. In this study, the cardiorespiratory event is defined as any drop in the saturation level below 80% with one of any drop in the saturation levels below 80% with one of the following: a drop of heart rate to less than 100, any poor respiratory effort requiring positive pressure ventilation, any need to start or increase the respiratory support for more than 1 hour by triple HFNC, CPAP, or mechanical ventilation, or the need to restart or increase the dose of capnia because of recurrent apneas. Statistical analysis. Stata version 16.0 was used for analysis, and the outcomes were measured as proportions. Univariate analysis was done using Fisher-Exact test, and multivariate analysis was done using logistic regression. The data was obtained after getting permission from the ethics committee of that particular institute. So the results obtained, a total of 161 neonates were included. Out of that, 17.4% neonates were less than 27 weeks. Cardiorespiratory event was noted in 21 neonates out of 161 neonates. 14 babies required triple HFNC support, and caffeine therapy was initiated in 6 babies. None of the babies required initiation of invasive ventilation or hypotension, which required IV fluids. The median gestation age was 28 weeks. Median duration of invasive ventilation was 1 day. The median age at which the first vaccination was received was 51 days postnatal, and the gestation age of first vaccination was 35 weeks. The cardiorespiratory events which occurred within the first 12 hours were in 11 babies out of the 21 total. Within 12 to 24 hours, 10 children, and after 24 hours, only one child had an episode. But none of the events occurred immediately following vaccination. So as we have discussed, these are the tabulated forms. The baseline characteristic of the study participants according to the gestational age, the average birth weight, need of respiratory support, association with bronchopulmonary dysplasia, culture positive sepsis, periventricular leukomalacia, and anemia requiring transfusions. This table highlights the risk, the factors which were associated with the cardiorespiratory events after vaccination. So we noticed that smaller the gestational age and more association with culture positive sepsis and BPD. And we can see that when the baby is having a respiratory support at 4 weeks postnatal age, the odds ratio is coming to 30.5. So when the baby is already on respiratory support, those babies had much higher risk of developing a cardiorespiratory event following vaccination. So the results, the lower gestational age, bronchopulmonary dysplasia, and culture positive sepsis. These were the significant risk factors on univariate analysis. And on multivariate analysis, the continuing need of respiratory support at 4 weeks postnatal age was the only independent risk factor for developing these cardiorespiratory events. The unit was compliant for age-appropriate vaccination in 123 infants. 38 infants who could not be covered, 25 of them were missed opportunities, and the rest of them were deemed unstable for vaccination at the time when it was appropriate to administer the vaccine. So in conclusion, the adverse cardiorespiratory events were uncommon after first vaccination, even in very preterm neonates. And administering vaccines in this group before discharge would rather allow us to monitor for any events, especially for those babies who need cardiorespiratory support. How this will help us? It will reiterate the importance of vaccination even in preterm neonates. And this article shows us statistically that the cardiorespiratory events were not related to the vaccination. And it will help us to form a protocol-based vaccination for preterm in tertiary NICUs. The limitation of the study. In this study, only 28 infants were extreme preterm, that is less than 28 weekers. So some more research would be required to make recommendation in this age group. And in KIMS Hospital, they administered the hexavalent combination vaccine. So no comparison was possible between different type of vaccination, that which component of the vaccine had maximum cardiorespiratory events that could not be studied in this study. Thank you.
Thank you, Dr. Sachi. It was indeed very crisp and concise presentation. So I request our expert, Dr. Umesh Vaidya sir, to comment on this article.
Yeah, thank you very much, Dr. Niket. And Sachi, congratulations for a very good presentation. It was very controlled, and I think you brought out the most important parts of this paper. Now, I would just add a few comments. The first comment I would add is this, this, believe me, as a neonatologist now, looking after many small babies.
Umesh, sorry. Sachi,
Yes.
can you stop sharing your slides so that we can each be on the...
Sorry, sir, yes.
Sir,
Yeah.
I thought that he might be asking for some references.
Oh, is it?
Yeah.
Achha, okay. Okay, go ahead, Umesh.
Yeah, so what I was trying to say was that as a neonatologist now, I must mention to everyone, I'm very sure everyone is aware that these babies below 30 weeks now, 95% of them would survive today. And we now, as you know, have gone down right up to 24 weeks and 26 weeks, and with IVF, there is so much of survival. So this kind of presentation that Sachi has done, this is very relevant to the neonatologist of today. And there are still, no matter what advances we have made, we are still a little bit of delay in vaccination. We are not bold enough yet to start immunization babies in the NICU. And I would here include my own unit also, where we would want much more stability before we consider this vaccination. So I think the relevance is huge for the pediatrician, and of course, a lot of neonatal people who do these long-term follow-ups. The important point that I would again like to emphasize here, that we are seeing a lot more BPD than what we saw in the past. We have many more babies who are ventilated for a long time. We have many more culture positive babies. No matter how much our sepsis is, we still get a lot of sepsis. And this high risk group that you have defined is the group that is going to stand in front of us for routine immunizations. The other important point is that though you have mentioned in this particular study that these small babies were vaccinated in the NICU, believe me, many people are still doing them at follow-up. And forget 1 week, sometimes even much later. Some people would give a BCG at around 2 kilos, then would wait for 1 more month, then for the other vaccinations, going in the same sequence rather than giving them together. Now, these vaccinations, the minute you delay them, you're going to be giving them in your OPDs. And every OPD, you may not have a very good environment to control any kind of emergency or apnea. Forget problems at home. You have shown 13% incidence of apnea and cardiorespiratory events. Now imagine these events occurring at home.
Yeah, you can show that slide, Dr. Sachi. You can show that slide. Yeah.
So my worry is that when these things happen after the patient goes home, you can imagine what kind of support they would have in case they get a cardiorespiratory event middle of the night. So that is the implication from my point of view. That is the fear that everyone would carry. The other point that I would like to mention that our own data, these small babies which go home, we have 17% incidence of readmission for other reasons. And some studies have reported 10% of post-discharge mortality. So when we are dealing with such a fragile population, we are dealing with smaller and smaller infants, we are dealing with BPD, we are dealing with babies who have recovered from sepsis, babies who are going home today with weights of 1600 and 1700. I think the first conclusion that this study adds is at least start your vaccinations while the baby is still in ICU in a very controlled environment. So it's a very clear message to everyone. Please do not vaccinate in a situation where you are unable to give any kind of support or monitoring to this particular child. So tremendous relevance. Secondly, all pediatricians who are practicing must have in their OPD some kind of a support system that in case you have a small baby who suddenly gets an apnea or is brought to you apneic or a baby is cyanosed, at least some kind of immediate cardiorespiratory support would be required. You may not have a CPAP or HFNC, but at least you should be able to bag that baby or provide some supplemental oxygen to pull the baby out of this crisis. I would also mention here that you said in the limitations of the study that the different types of vaccinations haven't been could not compare them. But again, what little knowledge I have about vaccinations, it is better that this high-risk fragile population maybe given DTaP rather than the wholesale vaccine. And it is known, whatever studies I have read show that the incidence of apnea and other adverse effects in the small babies would be lesser. So I would like Nitin to comment on this, whether what I'm mentioning is right or whether there's been any change in this particular policy. And we would prefer these babies to be having a DTaP rather than the wholesale, at least for the first vaccination. So I would like Nitin to comment on this.
Yeah, I mean,
And,
absolutely correct, because even in a full-term baby or a healthy baby, the chances of high fever, incessant crying, etc., is 10 times more with DTWP than with DTAP. So in a baby who is probably little unstable, preterm, past apneic spells, etc., is just being established on feeding and about to be discharged, or sometimes not even discharged, he's in nursery. There might be many other events that can happen, and if you precipitate one of those because of high fever or a lot of crying because of pain, I think that is not correct. So if patient can afford, DTAP is the choice of vaccine for preterms.
Right.
And there has been enough studies with rota, pneumococcal, and the hexavalent vaccine to show that it works as well in preterm as in a full term. So there is no worry about less immunogenicity or any other problem.
And one more thing, that this was a retrospective study. So when you have retrieved your records, I think there is a little bit of lack of precision in assessing the outcomes, because the data, the outcomes have not been recorded with the particular focus of the definition in mind. So there will be some limitations, but still the study does contribute greatly. According to me, 13.7% is still a pretty high incidence. It's 1 in 7, which I don't think is very, we really can't call it less common or uncommon. One would have to be prepared, because 1 in 7 babies are going to have it. So one would have to be much more prepared. So Nitin, I would like to have one more comment from you. So suppose the patient is already discharged when you're giving the first vaccination. Would it be safe to routinely give such a vaccination in an OPD where you don't have support, or where suppose you don't have oxygen or bagging or whatever? Maybe calling to the hospital, give it in the hospital setting where you have a casualty, the patient can wait there for some time. So would that be a better idea?
So all these preterm babies or high-risk babies who have been discharged, even full-term high-risk like infant of diabetic, child had convulsions repeated, etc., intracranial hemorrhage or whatever reason, they all are better given vaccination in a high-risk OPD. And high-risk OPD should have everything prepared. By the way, you must know that even a full-term baby, forget the babies, even an older child, infant or a 5-year-old child can develop anaphylaxis with any vaccine. And I at least get a call of one hectic pediatrician at least once in 3 to 4 months. There's some mishap of that can happen, anaphylaxis or anaphylactic reaction, and oxygen was not there, that was not there, this was not there, parents were upset and things like that. So we have to be prepared for any untoward reaction that can happen with any vaccine at any age. So you have to have running oxygen, you have to have adrenaline which expires very fast, you have to have IV fluid, you have to have support system. If you don't have it, then do not vaccinate in that area. Like suppose you are visiting some small nursing home once in 2 weeks, you should not give vaccine there. You should give vaccine under your supervision in your own clinic where all this is available. And you have to keep on checking, maybe do a mock run sort of, that suddenly you say, okay, where is oxygen, where is this, and you are a little better prepared. Because I have myself seen 3 to 4 anaphylaxis in my own clinic in my 35 years of practice. One was MMR, the second was measles. That time, both were made on egg embryo. Today, they are made on the human cell line. So that's a different thing. I have seen with HIB vaccine in Ahmedabad, young pediatrician just started practice, gave HIB vaccine, and the child died in his clinic. And he didn't have resuscitation ready. So that is pathetic. So that should not happen. So I mean, it can happen with any vaccine at any age. So you have to have all measures of resuscitation. And in fact, in the last vaccine CME, which was done in Mumbai in February, we gave a nice big laminated poster about how to manage severe adverse reaction following vaccination. I think that should be there in front of you in the room where you're vaccinating.
And more so for the small fragile ones.
Absolutely.
Yeah. So I think that would be a very important message from this paper to most of the pediatricians, that don't take these small preterm babies lightly. When you're vaccinating them, vaccinate them in a very good setup where you have support systems, counsel the parents properly, and for the high-risk infant, better to have them in hospital for the first vaccination when they're still in that age where they can get apneic spells and such things. So that I think would be an important highlight of this paper.
Yeah, and the other thing, Umesh, is that make the patients and the parents wait for at least half an hour in the clinic after vaccination at any age.
Right. Right. I think that's a very vital message, not only for the small population, but for everyone. So I think I would conclude my comments here, but if anyone else has anything else to say, or we have some questions on this, we can take them.
Can I add something?
Yeah.
Yeah. So another advice to everyone is please examine the baby before giving the vaccine. Examine, put a stetho, rule out any anomalies or any other mild illness and document it. Because I have had medical legal cases where the doctor gave the vaccine, child went home and was brought dead. And then they call up in panic. So I asked, did you put your notes? Because it was a preterm baby who was weighing 2 kg, referred from a private nursing home only for vaccination. So he did not bother to write notes. So what is important is any child who is brought to you for anything, it is very important you put your notes with your date, time, and signature properly, legibly, just to save yourself any medical legal problem later. Because unfortunate incidences can happen. How do you prove that this may be a vaccine related death or a child who may be ill baby or a preterm baby or he had some NICU stay or otherwise, whatever. So you have no way of protecting yourself. So that is one sincere advice to everyone where we try to make people aware about these medical legal angles of documentation. So please do that.
Yeah, and ma'am, what about a consent in this high-risk population?
No, so actually it is said that vaccination is an unspoken consent already taken. Now for a high risk, this thing in government hospitals, we are not taking any consent from anyone. They are given at the time of discharge. When everything is over, their antibiotic is over, they have gained a little weight. I don't do neonatology in JJ, basically, but what the practice is that we give it at the time of discharge. We keep the baby for 24 hours and then we discharge. And they are called for a neonatal follow-up that in a week's time. So there is a neonatal OPD in the afternoon. So they are called for that. Post
So I think,
Umesh, when a patient comes for vaccination to you, it's an implied consent. As the public health is not taking any written consent, that is not mandatory. But if you have any trouble, then the court can go either way. But I don't think so. I mean, I have seen some people taking blanket consent. That again has no meaning because you are supposed to take informed consent every time. I think the bottom line is there's no need of written consent, but you should have verbally told them. And as Dr. Bela said, very important, the pediatrician, however busy he may be, he cannot just leave the vaccination to the nurse, saying that ye laga do, exact jao laga do. Aisa nahi. He has to do it himself in at least this type of high-risk babies. I would say with any baby, because you are charging the patient for vaccination, you at least spend 5 minutes for well baby, height, weight, head circumference, feeding advice, look at some milestone, and then give the vaccine. So that is, I think, the way to go. I have seen many places, the nurses give the vaccine. They make mistakes. They may mistake the diluent is wrong or the only diluent is given, stickers are wrong, the vaccine has expired, no one is checked. And at least every 15 days I get one frantic call. As late as day before yesterday, that a sticker was put and it had actually shown expired vaccine. Now the parents are sued for 15 lakhs.
Yes.
So, so you have to be very careful. I mean, vaccination is, today it's bread and butter for most of the pediatrician. And there also, if you are not sincere, I think you should not practice them.
Thank you so much, sir. Dr. Umesh sir, Dr. Nitin Shah sir, and also Dr. Bela Verma madam for your valuable inputs. And now I request Dr. Bhavya Shah madam also to give her comments.
If Dr. Sachi can stop sharing the screen,
Yeah,
please.
yeah, Dr. Sachi, you can stop share now.
Yes,
and, Dr. Bhavya, she was supposed to give the comments on this paper.
She's joined, but
yeah, I don't think we can go ahead with the second paper.
Yeah, I think she's not there.
Can I call Dr. Bhavya, ma'am?
No, ma'am. Now, sir, now there is no time.
Okay.
Yeah.
Yes,
okay, let's move forward. Let's turn to our second topic of the day: low osmolarity oral rehydration solution in management of dehydration in children. So I once again invite our Raigad IIP Secretary, Dr. Ajay Kohli sir, for introduction of our second expert, Dr. Bela Verma madam, and our second speaker, Dr. Prashant Chavan sir. Over to Dr. Ajay.
Dr. Ajay, please go ahead.
Please unmute, sir, Ajay, sir.
Okay. Good evening, ladies and gentlemen. Good evening, friends. Our second expert for the day is Dr. Bela Verma, ma'am. Ma'am is professor and head of pediatrics in Grant Government Medical College, JJ, also known as JJ Hospital of Mumbai. Major achievements of ma'am are National IIP-EB member of IIP since 2022, National Medical Legal Group West Zone member, Joint National Coordinator for NTEP 2022, Maharashtra Task Force for Pediatric COVID Management 2021-2022, National Faculty for NTEP and ECD 24/7 Common Problems in Pediatric Practice and 98.7 FM FIVO module, President of Indian Academy of Pediatrics of Mumbai 2018 to 2019, and Honorary Treasurer IIP Mumbai 2013. The madam has 19 publications to her name, 17 national publications and a book chapter. Special interest, community pediatrics, medico-legal, infectious disease and nutrition. Thank you, ma'am, for gracing our today's journey. Next, our speaker for the second session is Dr. Prashant Chavan, sir. Sir has done his postdoctoral fellowship in pediatric intensive care in AMS New Delhi. Sir is medical director and consulting pediatrician neonatologist at Chavan Hospital, Sidco, Aurangabad. Sir is also secretary and CEO at Adarsh Cooperative Hospital, also at Aurangabad. Sir is treasurer of Aurangabad Academy of Pediatrics and executive body member of IMA Aurangabad. With this, I welcome both our expert and Dr. Prashant Chavan, sir, to please start the presentation. Over to you, sir.
Prashant, sir, unmute.
Hello, good evening, all. I hope I'm audible. I'm Dr. Prashant. I'm very fortunate to have to share my all presentation with all my seniors. Like Bela Verma ma'am was my when I was a former lecturer at JJ Medical College. Ma'am was there. Nitin Shah sir, Chitra ma'am, Mohanty sir, all our seniors have given me good opportunity to present myself. And today I'm going to present this topic. Actually, this is not a journal. I think this is the recommendation given by IIP, which was published in last year. So the recommendation name was the low osmolality oral rehydration salt solution in management of dehydration, not in diarrhea. Remember, so this is about dehydration in children. And the chief author of this publication was Neeman Mohanty sir, and he is present now today. He has guided me well throughout this topic. And it was published in Indian Pediatrics, volume 58, March 2021. And the impact factor, that is very important, impact factor of Indian pediatrics is 3.89, and which is just updated in 2023. So with this introduction of topic, I will start with the topic. Now, why there was a need of giving this recommendation? And it was already, we know that IIP has already given this comprehensive management guidelines in 2006, and a review again was done in 2016. So again, still after 15 years, we again need another recommendation for dehydration management, whether it may be caused by diarrhea or any other cause. So WHO has shifted from it was standard ORS was launched in 1978 for the management of cholera-like diarrhea. Now we have shifted to low osmolar ORS in 2022, and Indian government has adopted this low osmolar ORS in all its national programs since 2004. But still, the use of current at present lower use of low osmolar ORS is as low as 51% only. Beside the awareness of this use of ORS, or the establishment of the effectiveness of ORS in dehydration was increased from 14% in 2005 when it was launched to 69% in 2015. still we have this low penetration. Even we are all are aware of the importance of ORS. And to add confusion to practicing pediatrician, healthcare workers, our staff, and everybody who is prescribing and writing and using ORS, there are different composition of ORS are available: liquid formulation, powder formulation, different name, brand names, different flavors, everything. So all this made the Indian Pediatrics Academy, IAP Academy, to come forward with the recommendation. And what was the process? They said the field expert from the field of pediatrics, pediatric gastroenterology, and dietitian. So they sat twice, 2018 June, and again in August 2019. They reviewed all the data, recent literature reviews, recent RCTs, and everything they have reviewed. And again, they have formulated a draft which was circulated among all these experts. And in 2020, March 2020, this draft was approved by executive body member, and it is published in 2021. So what was the objective of this recommendation? To summarize and guide our all pediatrician healthcare workers in India to summarize the literature what is currently available on all oral rehydration therapies. So, so some background. Already we know that diarrhea is a second, currently also today also in 2023 also, diarrhea is the second leading cause of death, and in the less than 5 years of children. And most commonly, this diarrhea is causing dehydration, and this dehydration complication is responsible for all the deaths of this dehydration. And in third world countries like India, near South Asian country, the dehydration and malnutrition go hand in hand, and they are causing this second most leading cause of death in children. And the simple solution for this management of this complication, like this dehydration, is the rehydration, and which is now proven with the ORS we can do that. So as I told you, 1978 was when the oral standard rehydration solution was launched, and it was changed to 2002 in low osmolar ORS solution. And the safety and efficacy of this new low osmolar ORS was well endorsed by the ESPHAGAN and NASPHAGAN all over world. Now it is proven. There is no doubt about any safety about and efficacy about low osmolar ORS. Now again, as everybody, why we are discussing everything this, today, because we know Dr. Dilip Mahavalins, he was working in refugee camp in Bangladesh during the British Empire. He has invented this ORS solution, oral rehydration solution, with the use of salt and sugar and water. Why did he was able to do that? Because Indian manuscripts like Sushruta, already used this oral rehydration type of therapy 2005 years ago. What he was using: rice water, coconut juice, and carrot soup. It was documentedly available that this solution is used for the diarrhea like dehydration in 2500 years ago. Now, with the invention of these IV fluids and everything, in Western world, in like 1831, William Brooke treated the cholera patients with IV fluids, and it has reduced the mortality from 70% to 40%. So this IV fluid replacement became the standard care for the management of dehydration, which may be the moderate or severe dehydration for the patient with diarrhea, mostly due to the cholera. Now again, we are coming back after 2500 years again. The Dr. Hemendranath Chatterjee was started using this oral therapies for managing the patient with the dehydration. And finally, in the cholera epidemic, which and pandemic also, in the refugee camps in 1971, he has started using this Dilip Mahavalin sir, which was awarded with Padma Vibhushana and he died on 16th October 2022. He was using this oral rehydration solution, and it has shown that it has reduced the mortality to only up to 0.36%. So as Lancet has already given its statement that it is the greatest discovery of last century. So no matter the MRI machines or whatever you may call as a tech savvy things you are witnessing today, but the simple water salt glucose solution has saved the million and billions of life. So it is the century of the invention of the century. It was published in Lancet. So the man behind that was the Dilip Mahavalin, and we are his first anniversary is coming on 16th October 2023. So why the ORS was working? Simple, a small thing was discovered in early 60s. it was the glucose co-transport system. As molecular biology is developing, this glucose sodium co-transport was the mechanism behind the absorption of water, salt, and along with the glucose, and that has contributed. It was now documented after the use of ORS. This co-transport is responsible for the correction of dehydration and with the use of our oral dehydration therapy. Around same times, it was also discovered that the intestinal mucosa is not disturbed in patient with cholera, because at the time cholera was the major disease that was causing dehydration and morbidity and mortality. Again, coming back to our recommendation paper, so there are 3 to 4 mechanisms of secretory diarrhea. Most commonly, we know that secretory diarrhea is there. Here, the toxins are causing damage, and it is causing active output of fluids from the small intestine, and most common causes are enterotoxic E. coli and cholera. Now we have less incidences of cholera. And second was the osmotic diarrhea. Here, the unabsorbed mostly the carbohydrate is causing the osmotic load inside the lumen, and it is dragging the fluid and electrolyte from the inside your lumen, and it is causing high purge diarrhea. So that is your osmotic diarrhea. And the secondary lactose intolerance that is caused by rotavirus is also due to the osmotic diarrhea. Now we have the bloody diarrhea, where all the visible bloods you can see in the stool, which is called as dysentery, and it is associated with the systematic symptom like fever, colicky pain, cramps, and everything. And it is due to the electro-invasive E. coli, Shigella, and Salmonella. Lastly, the malabsorptive diarrhea, where there is a diffuse mucosal damage, pancreatic, biliary system involvement, celiac disease, Gall disease, cystic fibrosis, are these all causes of the malabsorption diarrhea. Now, why now there is a need of shifting this from the standard ORS to low osmolar ORS? Because we are starting using, and we have already said that it is the invention of the century. Why we are shifting from this standard ORS solution to the low osmolar solution? So there are some reasons, because there are improved sanitation, improved infrastructure, improved water supply to all over the Indian countries on South Asian country. So there are less incidences of cholera nowadays. So cholera incidence has decreased, and there are when you see the stool losses. Here you can see the table I have shown in the. So when you see the cholera stool here, so the sodium loss is 105. And when you compare with the non-cholera stool, mostly what we are getting today is the rotaviral diarrhea in children's. And here you can see there is a 50% reduction of the sodium loss from the stool. So that's why we don't need this standard ORS, conventional ORS, which is having higher amount of sodium. Now we can very well use with this low osmolar ORS. And with this use of this higher sodium concentration of conventional ORS in non-cholera diarrheal disease, we are getting some incidences of hypernatremia. There is a high purge rate that is persisting, vomiting, and poor acceptability from the parents and mother. So that's why these are all reasons are coming. That's why we have decided to shift from the standard ORS to low osmolar ORS with the lower osmolarity, that is 245 now we are having in low osmolar solution. So less incidences of hypernatremia in non-cholera like diarrhea. And again, I told you there are less incidences of vomiting and stool volume, and early recovery and better acceptability by the mother and everything. That's why we have shifted from this standard ORS to low osmolar ORS. Now recommendation, the most common recommendation is the watery diarrhea, where we are going to use standard low osmolar ORS for the dehydration. And when we are going to treat the watery diarrhea, whatever will be the cause, most commonly we have the rotaviral disease. Here, we need to continue the oral dehydration therapy, that is with our standard, low osmolar ORS, and we need to continue feeding. That we need to emphasize here. We need to continue feeding. Whatever we be feeding, if patient is baby is exclusive on exclusive feed, then we need to continue exclusive feed. Patient is having on complementary feed, we need to continue that complementary feeding, and we need to give supplementation, because in Indian continent we have the poor soil content of zinc, and there are most of the 50% population or more than that is our vegetarians. So we have the less zinc supplementation from the diet, and it is the severe loss we can see from the diarrheal episode. So we need to continue supplementation with zinc. Again, WHO has given the standard classification of dehydration. No dehydration. Then here we are going to give as there is no dehydration, we are going to replenish whatever the losses are ongoing with the 10 ml per kg of low osmolar ORS with each episode of diarrhea, again with the continued feeding and zinc supplementation. Second is the some dehydration, where we are going to use plan B. It is the case of mild to moderate dehydration. So we will treat patient in a daycare or in the ORS corner setting, and we are going to rehydrate also, and we are going to cover the ongoing losses with the low osmolar ORS. So how we are going to cover the dehydration? With the 50 to 100 ml per kg of body weight, which is around 75 ml per kg, and ongoing losses 5 to 10 ml per kg. With the ongoing losses with the stool, we are going to replenish with the low osmolar ORS. And lastly, we know that when there is a severe dehydration, and same criteria, 10 clinical signs are used for to dehydration of these no, some, and severe dehydration. Most specific are your absence of tear, skin turgor, capillary refill time, are more specific for determining the dehydration status of the and classification of dehydration. And for severe dehydration, what we are giving either in transit to the patient. For higher center, we are giving to NG tube, or we are giving IV boluses, and as it IMNC product, we are also giving him the injectable antibiotics intramuscular and shifting to higher center. Now the second recommendation of this dehydration comes with the severe acute malnutrition. Even though today we are now witnessing many patients of malnutrition, where what we are going to do, we are going to and we know that there is a higher mortality of the when dehydration occurs or severe diarrhea occurs in patient with malnutrition. 8 to 9 times there are more chances of the patient go for the worst outcome. So that's why we need to slowly, not quickly, correct the dehydration in patient with SAM, and we need to also continue the feeding with F75 diet. And what solution we are going to use? We are going to use Resomol, and IAP in 2016 also given the modified Resomol, where the sodium content is 45 millimole per liter, potassium is 40 millimole per liter, with addition of zinc and copper and other elements. So remember, here we are not going to correct the dehydration very fast, but we need to go clinical examination, urine output, pulses, and everything we need to monitor, and then we need to correct the dehydration slowly with the Resomol or modified Resomol. So now there have been studies, RCTs done, where we can use low osmolar ORS with the patient with SAM. So studies have shown that you can use that, but with the addition of potassium. So what solution we can use? We can dilute we can take 1 liter of water and add the low osmolar ORS and add 15 ml of 20% of K-sol. So you will get the potassium concentration, and you can start using and you can start correcting the SAM dehydration in SAM patient till the time you get modified Resomol or Resomol. But the problem, the RCTs have shown that the two problems are there when you are going to use low osmolar ORS are the hyponatremia. There are chances of hyponatremia. So you need to monitor the patients who are on low osmolar ORS with the SAM patient, low osmolar ORS, and there is a chances of over dehydration in such patient. So it may be the detrimental for this patient. So you need to monitor this complication while using this our standard low osmolar ORS. So this is how you can convert our low osmolar ORS with dissolution in 1 liter of water plus 15 ml of 20% K-sol, and you can start using in the patient with SAM. So now other are some indication given by this paper or this recommendation, which are also important. So neonates, as neonates have the larger body surface area to body mass, so there is a more loss of water, insensible loss of water. So there are more chances of hypernatremic type of dehydration in such patients. So this recommendation is not going to recommend use of low osmolar ORS in babies less than 2 months of age. So this LORS is going to be, we are going to use in the babies who are more than 2 months of age for any type of dehydration in such patients. And below that, we need to monitor electrolytes and everything, urine output and type of dehydration, cause of dehydration, and we need to modify the according to electrolyte imbalance. And the second indication was the severe dehydration cases where there is no facility of IV fluid is available, where we are giving this low osmolar ORS with the use of NG tube, and we are going to give this 20 ml per kg over 6 hours, and we need to monitor patient every 1 to 2 hours. So through NG tube, you can start giving this low osmolar ORS and shift patient to the higher center or referral center. If patient is having vomiting, so what you can do, even patient with the moderate and severe dehydration, if patient is taking orally, you should try to give orally. And if in the smaller sips of 2 to 3 ml per kg, You need to wait for 15 to 20 minutes after the episode of vomiting. Still patient vomits, you can try with the ondansetron 1.5 mg per kg, and it is all given in the paper only. I'm narrating same things, the dose and everything. So same dose ondansetron you need to give, and we need to wait for 15 to 20 minutes, and again try with the low osmolar ORS and shift patient to higher center. So renal failure patients, here you can start with the low osmolar ORS, but you need to be careful for these patients because there are more losses of bicarbonates and electrolyte imbalances there. So you need to start the correcting dehydration with low osmolar ORS, but you need to taper the dehydration therapy according to the RFTs and KFT reports. So the most common indication that would be for all our pediatrician would be practicing pediatrician with the acute febrile illnesses, which was most important indication, I think, in addition to the diarrhea, because every day we are going to see these patients of viral fever, dengue, typhoid, malaria, and heat stroke in summer season. So in each and every patient, it is now recommended by IAP Indian Pediatrics that you should start when there is a fever, high grade fever. There are almost 20% of extra water intake baby should take, and in addition to that water, we need to also give electrolyte. So for every febrile illness, you should start using this viral means like ORS, low osmolar ORS. Finally, the NFHS has given this data. You can see this data is very important. What is the use of this ORS that is being used? So here you can see in 2005 and 6, so 26% children are receiving. This study is done in Uttar Pradesh and Gujarat, three districts each. They have analyzed the prescription used by the doctors, and in government setting also, in private setting also. So the results are that in 2005 and 6, 26% children with diarrhea or dehydration are receiving only our standard ORS, and it has increased in 2015 to 16 to 50%. So almost double the prescription rate has been increased in down the line 10 years. Zinc supplementation is started, and the treatment given in the healthcare facility was also almost same. So this states that we are starting using ORS or prescribing, but still we need to prescribe more and more, and to every patient with the dehydration, some dehydration as per the classification, we need to taper the solution. Now another thing that marketing pharma people, what they are doing in our day-to-day practice is that they are asking us to write all these soft drinks, sport drinks, or energy drinks, so-called, as for patient with the dehydration or febrile illness. So you can see there are huge differences when you compare with our standard ORS. So you can see the osmolality of fruit juices. Most commonly we should say, we are saying the fruit juice dos ko ye karo wo karo, but there is a huge difference is osmolality with our standard ORS or also in low osmolar ORS. And you can see the sodium content. So this is again in millimoles, not any other parameter used. Still in millimoles, you can see very low sodium content, huge quantity of carbohydrate you are pushing, and that causes a higher osmolality. So that is not going to correct your problem of dehydration in any patient. Like it may be due to your febrile illness or diarrhea or anything. So we need to be very cautious while using or prescribing this or telling our patients the sport drinks, soft drinks, and fruit juices. So now we have this intensified diarrhea control program, which was launched in 2014 by Ministry of Health and Welfare. So what we are doing here, we are celebrating this ORS week from 20th July to 3rd July. And here what we are going to do, a government is doing that. We are going to promote the use of ORS in healthcare workers. We are collaborating with NGOs. We are also IAP since last how many years we are celebrating these ORS weeks. So very motive of this IDFC program is to promote the awareness of ORS in healthcare workers, in public, in everything. We are going in schools as IAP. We are going in schools and everywhere. In Aurangabad also we are going in school. We are school teachers and students. We are also promoting healthcare workers, primary healthcare workers, Anganwadi workers. Everywhere we are going to. Very motive of this IDFC program is to promote the awareness of ORS. Now I'm coming to last three slides only. So now what are the barriers? Why still there is a poor use of this low osmolar ORS? I have said that this is the invention of century. So lack of awareness. Still we are convinced with the use of this proper ORS and efficacy of ORS. We are very reluctant to prescribe because we are not aware. We are going with fancy things like bottle, ready to use, flavor and everything. So there is a lack of awareness that standard, our powder form is also well used. So there are pharmacy companies which are also going to affect, and they are going to do marketing And for the profit margin reason, they are coming with different formulation, different flavors, different colors, and ready to use formulations. So many branded formulation, you must be knowing better than me. There are many formulations available that are being used all over India. They are also our barriers. So that's why we are not preserving our low osmolar ORS. And there is no regulatory mechanism at present also in India. What we are asking from this recommendation, one India, one ORS. So there should be standardized regulation from the regulatory authority all across India, that there should be a regulatory mechanism who can write WHO ORS or low osmolar ORS. So there is no still any regulatory mechanism in India at present. And still we need to also tell our parents and our students that there is a palatability issue of ORS that is due to your addition of citrate. And citrate is very important content to stabilize the pH of the powder solution. So that's why we need to use this standard ORS. We need to convince our parent that it is going to have some bitter taste due to for the stability. And recently, in last week only, the DCA has approved the use of zinc in the powder form of WHO low ORS solution. And even though parents are going to insist us to give IV fluids, we need to stay on our classification. When in only severe dehydration patients, we need to give IV fluids, and otherwise in no cases. So last slide. So what the research we want to do further in respect to this ORS. So we need to again improve the calorie content without compromising the osmolarity. We need to improve the palatability of low osmolar ORS without increasing the osmolarity. So palatability is most issue. Everybody is going to accept that the palatability is issue. So we need to improve on that. We need to improve some of the calories. So it can be given in a small quantity, huge calorie can be given. We need to address safety in the neonates and young infants and in patients with renal failure. So we need to find such a ORS again. And in a patient with ORS, because Resomol is very difficult to procure and everything. So we need to find some solution for the patient with severe acute malnutrition. I think conclusion. So advantages of ORS we have already known. We need to promote better awareness of and non-diarrheal disease. We need to start using more research as I already told you. And we need to have one India, one ARS policy through all our regulatory mechanism. Thank you.
Thank you, Dr. Prashant. It was a very informative, very excellent and clinically oriented presentation. Now, I would just like to request Dr. Bela Verma, madam, to give her expert comments on the paper.
Yeah, thank you, and good evening, everyone. So, Prashant, this was a very well concised and presented article. And since it is a recommendation article, there is no critical appraisal of the article here. But the bottom line in capital letters for everyone is that ORS works. It saves lives. It saves deaths. It prevents dehydration. So the motto of giving ORS or ORT in diarrhea is prevention of dehydration, which is a leading cause of death in diarrheal diseases. Also, here the NFHS 4 data is presented. It has changed now. So the NFHS 5 data of 19 and 21 is very heartening. In fact, the use and the awareness of the ORS in young mothers is more than 94% as per the latest NFHS 5 data, and ORS has been used more than 90% in the last 4-5 years. So that is very heartening to learn. And also the incidence, which was 9.2 of diarrheal incidences or diseases, is now down to 6 to 7%. So that is the latest data. So our hard work of creating awareness and propagating it has definitely worked. And other thing is that except in the far eastern states of India where the use is less than 50%, maybe we need to propagate and create awareness more. Other than that, I think it's a very well written article. You brought across all the points very well over here. What I would like to highlight as per my experience in a government hospital is we need to create awareness among all class of people. So, it is not something which is used for the slums or lower class of people, because the higher society prefers a Tetra Pak maybe. That is more high society. So the thing is, the WHO recommended ORS powder that we call is the one which is to be used. That is one. Second, of course, no fancy Tetra packs, no fruit juices, no soft fizzy drinks, which is again considered, "Are bacha Pepsi to pee raha hai." You know, he is drinking something. So that is another wrong concept. Other thing that I realized is the method of preparation. It is very sad to see people don't know how to prepare it. So they'll have a 1 liter wala sachet. They will take a glass of water, put 2 spoons and give. So what needs to be told is it's an entire sachet in 1 liter of drinking water. Okay. If you tell them, aap pani ubal ke usme banao, so they'll put 1 liter for boiling and after 5 minutes, 3/4 liter is left. So these are errors which are occurring because of poor knowledge of preparing it. So 1 liter of drinking water, 1 entire sachet to be made. It can be kept for 24 hours, should be covered and kept. How much to be given? So roughly we say 1 cup pani, 1 katori pani. You know, we have to tell them an approximate measurement. They don't have a measuring cup at home. So when you have illiterate mothers coming to you and others, you need to give them an approximate volume. Ki itna dena hai. That is for plan A, of course. That is one thing I realized. Ki actually demonstrating it works. Visual training works more than verbal training. Okay. So whether you have videos running in your OPD or whether you demonstrated yourself makes 100% impact. Okay. That is one thing.
Okay.
Other thing, it should be freely available everywhere. Urban, rural areas, free of cost. A poor person will not buy it, even if it is 10 rupees. Okay, so it should be freely made available by the government of India. And of course, another important thing, do not withhold the diet. What happens is, बच्चे को जुलाब हो रहा है, उसको खाना मत दो. Input नहीं होगा तो output नहीं होगा. So that is one thing. Regular feeding should go on, and extra food, extra one diet for 2 weeks for that child. These are some of the things. Of course, zinc has been added, which is known to reduce the diarrheal episodes and also decrease the duration by at least 24 hours. That is another thing. And of course, it is safe in SAM. Your low osmolar we have used in SAM because Rizomal we do not get in government setup. I have not found a single case of hypernatremia happening in SAM. Oral rehydration works well even in SAM in a controlled way, of course, because the urge to push IV is very severe in residents. Unko wo pinch, turgor lost lagta hai. Okay, so teaching that a lost skin turgor in a SAM does not mean dehydration. That is important. So you do slow rehydration in those patients. So what I mean to say, it looks very good when we discuss it among ourselves. It has to reach the community. So it should not be a single ORS day or a week. No, it has to be round the year, 365 days. It has to be a daily health training. So wherever in your OPD, in your ward, if your staff is trained. So we have this program running by government last 3-4 years, of course, supported by an NGO called the Care Companion Program, CCP, where there is a ready-made colored booklet to train the mothers visually. So breastfeeding, complementary feeds, dehydration, immunization, some 4-5 concepts are covered. Even our residents regularly teach this. And the importance with the very first loose stool, ORS should be started. The very first loose stool, ORS should be started because it prevents dehydration. Not when 2-3 loose motion ho gaya to hum de rahe. So that is few things. My own personal experience I'll share. Last 3-4 years in the summer months, because of the excessive sweating, I feel exhausted. I started taking 1 sachet of ORS in 200 ml, the small one. Believe me, it just revives my energy. So the non-diarrheal use of ORS is definitely there. So taking it in non-diarrheal illnesses really peps up the patient. I take it once a day in the horrible summer months of May and maybe pre-monsoon. And of course, lots of water, 2.5, 3 liters of water, but I take 1 small sachet of ORS myself. So the use is phenomenal. And we should be very proud it was an Indian doctor who discovered or invented it. So the topic you chose today is extremely vital topic for every paramedic, medic, healthcare worker. It is not something that only a doctor should know. Every staff nurse should know, every Anganwadi A&M should know, every household should know the use of ORS. So I feel it was a very good article to be chosen. And it is very well written by all the authors. Only we need to reach it to the community.
Thank you, ma'am.
Thank you,
Our
madam.
Mohanty sir is there. He has written.
Sir, please unmute.
Thank you. Both the speakers have done an excellent job and very crisp and to the point. Of course, Prashant has he has his limitations because the article are so long. Madam, whatever Dr. Bela has told us is all there in this paper. Actually, the audience are requested to just go through that paper. The one which is all very detailed, so difficult to present in a very limited time like this. I was fortunate to be in these refugee camps, in Bangladesh refugee camps. I worked there for 6 months. When this Maldives working there. And those the difficult days when this shelling were going on from Pakistan side, and all this healthcare personnel ran away from those areas, from Bengal. And we were all the volunteers from the UNICEF or Oxfam, we were only left with few untrained Bangladeshi refugees who took them and trained them, and what to talk of IV fluid administration, very difficult. So these things were a stopgap arrangement was made, but it took a lot of time to come to the society because, see, it was started in 71, it was invented, and it took so many, about a decade to WHO to give an approval. So when it started, this result came from 30% mortality to it reached 4% with use of ORS in UK. They only woke up and started recommending this SBGAN and NASBGAN. They did it. Now, what Madam has said is enough. Now, I can only add here one is Dr. Nitin Shah is here, our leader. He is. We should take up with the government to declare ORS as a drug. Relatives, the parents, they come asking for some medicines for diarrhea. They are not convinced with this as a, but if you administer this as a medicine and at the appropriate the level recognition, everything will be probably the ORS will get, and we should go rapidly, promptly to achieve our goal that one ORS, one India. That is the message in this article. I will not spend much of time, and I'm grateful that all the speakers have done very well. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, madam. And now I request our Maha-IP President, Dr. Ramakant Patil, sir, to give his comments on both the papers.
Ramakant Patil, sir, please.
Ma'am, Ramakant sir नाही दिसत आहे.
Okay, go ahead, Dr. Swati. Next.
Okay, so
any questions?
Yeah, any questions? Dr. Jai Bhandarkar sir can just take a few questions if they are on in the chat box.
One was there about the brand of vaccine which is to be promoted for preterm and extremely preterm. That was the question. Expert Dr. Umesh, can you take up? Nitin Shah, sir. Okay, go ahead. Any other questions?
मैंने फिर टेस्ट कराया, वो टेस्ट बोल दो एक बच्चे को।
Okay. Move ahead. Swati.
Okay, it was a pleasure having such wonderful speakers and eminent experts today. And on behalf of Journal Journey, I value the insights and guidance provided by our experts and also the guest of honor. And it's an audience like you all that makes this presentation awesome. Thank you very much for your unwavering attention throughout the presentation. And I'm confident that we all have learned a lot of new things today. And I'm grateful to each and everyone who attended today's Journal Journey. And I look forward to see you all for our next month's Journal Journey. Also, our next month's experts and speakers will be announced by Dr. Amol Pawar, Maha-AP Secretary. So, Dr. Amol Pawar. He's not there.
One of the presenter, Dr. Tirumal from D.Y. Patil Medical College will be presenting the next article on 1st of September.
Yes.
Yeah, Dr. Amol, please announce.
Somebody is. Wait a minute. Huh? So Dr. Bela Verma ma'am is also sending one name as a presenter. He will be a senior resident, and another is from Kolhapur. I just ma'am announced. He has joined, I think, in meeting. Are you there, Dr. Thendral Yam from Tamil Nadu? Are you there? Are you there, Dr. Thendral?
Yes,
so
sir.
He
Yes,
has
sir.
done his. Hello.
Yes, sir. I'm there.
Ma'am, Chitra ma'am, Nimen sir. He is there. Can you start your video? Can you? Dr. Thendral.
Yes, yes, sir.
So Nimen sir, Dr. Thendral, he has done his UG from Sri Siddharth Medical College, Karnataka, and right now he is doing PG. He's a final year student, and he's doing MD Pediatrics from D.Y. Patil Medical College, Kolhapur. And Dr. Nivedita Patil ma'am, who is a zonal coordinator from Western Maharashtra, Maha-AP Women's Committee. She is also HOD of that college, and she has given his name. And Dr. Bela ma'am will be giving the second presenter name. So we'll be having one from Mumbai and one from Kolhapur. So Dr. Thendral, please introduce and tell us.
Good evening, everyone. My name is Thendral. I'm final year resident in D.Y. Patil. I like to this opportunity very well. I like to use the opportunity very well.
Nimen sir, can you give him his first topic so that he can take up and we'll start preparing. Kindly unmute, sir. Kindly unmute. Nimen sir.
Yes, Dr. Thendral. It is our practice to give the option of the presenter to choose your own topic if you can. Otherwise, we will give the topic by 5th of this month. We'll give the topic.
Okay.
See, if you search the topic, in the course of that, you will have to read about 5 to 10 topics. That is a plus point, is a kitty in your pocket. So if you do that exercise, it will help you. Otherwise, what is your area of interest?
Neonatal, sir.
Okay, so we'll give a topic on neonatology. If you don't find one suitable, we'll give a topic in 3-4 days time. I'll give it.
Okay.
Actually, Nivedita ma'am asked that whether they can take a choice, they can take a topic of their choice. But I told we have Dr. Nimen Mohanty sir. It is usual practice that he only gives the topic.
No, actually, this was evolved because only to allow them to search, so that they have to, it is a must to go through more and more topics. In that process, kafi padhai ho jata hai. So otherwise, we'll give them the topic.
Sorry
Yes.
to
Let
disturb
them
you,
do
sir.
it. Yeah.
Shall I stop the YouTube like streaming?
Yeah, please.
Yeah.